A little bit about me. I love this industry. I love absolutely everything about the business of medicine. I love compliance, billing, coding, risk adjustment. I absolutely love it all. And I have been a part of the Southeastern Telehealth Resource Center for about 8 years now. I think I fell in love with telehealth when I was a little girl watching the Jetsons on Saturday morning. Do you remember that? I thought that was absolutely fascinating, how everything could happen so easily. I'm still looking for that little Zoom car that goes by itself, but don't we have some of those already? A few little, yeah, it's coming. So, yes, I also have a podcast. I host a bi-weekly podcast called Coding with Christine Hall, and we talk about everything that has to do with coding and reimbursement and compliance. So today we're going to talk a little bit about what's telehealth, telemedicine, like what is that and how does that work? And then what are some of the requirements of telehealth from a reimbursement perspective? Now, there are a lot of agencies out there that have received grants and fundings to do some amazing things with telehealth, especially when it comes to children health, behavioral health, and some of those projects out there. But I'm kind of looking at it from the consumer's perspective, right? How do we get our telehealth visit paid? How do I get to see my doctor from my living room, right? How does that work? We're also going to talk a little bit about how Medicare really sees it, because Medicare is one of the largest payers out there. It's a federal payer, and Medicare seems to dictate or facilitate how those commercial payers are going to receive telehealth services. So we'll look at that. Now, does anybody remember something that happened a few years ago called the pandemic? Changed our lives, didn't it? Well, I heard it's over too, but then I heard, oh my God, it's coming back. And I'm like, oh. And for me, between 2020 and 2022, it was just like one big year. So when they... Right. Yeah, that's where I'm telling you. So it's very difficult there. But a lot of things changed. They changed fast, because we needed them to under the circumstances. And so now we found ourselves post public health emergency. And so they say, allegedly, I'm going to start using that, allegedly. Right. Correct. The official declaration of the public health emergency has ended, and some of the things that public health emergency provided to us have ended, and some have been extended. However, I think it's kind of important that we get to the bottom of it. So bear with me. Now, there's a lot of confusion about what is telehealth and what is telemedicine. Honestly, they're synonymous. I mean, really, we're just talking about providing healthcare through technology. And that is the true definition of telehealth. And then telemedicine is intended to be the modalities that we use to provide that. So, for example, I've got this smartwatch on. Anybody got a smartwatch? Tells you what to do all the time. Stand up, walk, you're almost there, you've reached your goal, right? And some of you might have it set up so that it tattletales on you to your doctor's office. Did you do that? I did that. I don't know what I was thinking. I was like, oh, look, I can link this and link that and link. No. So doctor knows I don't have steps in, right? We also use audio video communication. We use our cell phones a lot. And now I think anybody that is maybe under the age of 20, that's the only way they communicate is the audio video. So they're constantly, my nieces and nephews are in college now, and they're constantly calling me on audio video with all their friends hanging around. And I just woke up, had woke up face, right? Yeah. So audio, video, communication. We have the patient portal that we use a lot. And we have a lot of electronic devices now that sync into our apps and even sync into with our providers through those portals. So our whole family went on a diet, and we got this really cool scale that it transports data to our cell phones, to this app on the cell phone, right? So 3 months into it, my husband's down like 40 pounds. Every time he gets on the scale, it sends a ding and it says, you've lost another pound. I get on the scale and the whole family gets a ding. Mom gained another pound, right? Yeah, rude. Anyway, we have these devices now that can record this data and help provide this data to our providers. I work with a really big group of doctors in Alabama, and they have a remote patient monitoring where they monitor newly diagnosed hypertensive patients. How incredible is that? So that they have a blood pressure machine there, and it's not a forever thing. It's simply until they get the hang of how to help themselves keep their blood pressure down or how to keep their blood sugar down with a new diabetic patient.
Like how they use the telephone to check and synchronize the pacemaker.
Yes, that was telehealth back in the day. Now, from a benefit perspective, that's a little bit different. But yeah, that's OG telehealth, right? Yeah. We find telehealth to be really helpful in many different areas of healthcare. Generally healthy patients. So those patients that don't need to come into the office, maybe they're just there for a checkup. They're doing great. Your blood pressure is down. You're taking your medication. Mission accomplished. Did you need to come into the office during the pandemic where everyone was sneezing, coughing, wheezing? Maybe not. Maybe a telehealth visit to give you that, yeah, you've met those goals. Some patients with chronic conditions. So again, talking about those hypertensive, diabetics, we talked about asthmatics earlier, those types of patients that maybe they're doing well now, or they need a medication tweak, but can't take the time to come into the office, right? Those can be facilitated through telehealth. Kids, do you ever pick up your kid after school and they're burning up with a fever and the doctor's office is closed now? So what do? Do we take them to urgent care? Do we take them to the emergency room? Do we just try to wing it tonight and see if it gets better and maybe we can get in tomorrow? Telehealth has really facilitated in that aspect, especially when it comes to pediatric medicine, being able to do that telehealth visit with that child at home where they probably want to be. Pregnant women, I don't know about you, but I remember that towards the end of my pregnancies, trying to lug myself and this other person that was living in my body to the doctor's office to be weighed and measured. You're doing great. Okay, thanks. Sometimes they're able to do some of those visits via telehealth. And again, I'm talking about what's appropriate. Another one, geriatric patients. So thank God my mom is a relatively healthy person. But now at this age, she needs someone to go to the doctor with her because she only picks up every other word that the doctor's telling her. She's more concerned about the social time that she's having at the doctor's office. So I go with her. But it's not just go to the doctor with mom. It's go to the doctor with mom, then go out to lunch with mom, and then go to the house with mom, and then, sit and hang out with her. Not that I don't want to, but I'd rather be home, I'm not going to lie. It would be much easier for me in my life and for her if we could do a telehealth visit, a 3-way telehealth visit, right? Yeah, exactly. When we were using Zoom, when that was allowed, we were doing 3-way Zoom meetings with mom's doctors, and that was great. Because again, she's a relatively healthy person, so it was for her annual wellness visits or her just a little routine checkup she was having. Behavioral health. This is where we saw the largest benefit was in behavioral health. I mean, think about the concept of behavioral health. For some of those patients that they have finally come to the moment where they've said, I believe that I do need some assistance with these problems that I can't deal with on my own. And then to have to drive to an office in a very sterile environment and pour your heart out or your what has happened or how you've become this way. And then in an hour, they tell you, okay, pack all that up, get back in the car and go home, and here's some homework for you. What we found is those patients that are able to have those face-to-face telehealth visits where they're in their home with their cup of tea, with their blankie, and they feel safe to talk about these things, how they're feeling, and really receive good information. That's been incredible. So to understand where we are today, we have to go back. We have to go back in time and we have to understand what the true benefits for telehealth are. And I'm talking about payment. How do we get telehealth paid? There's a couple of ways. One, my kids all use those apps for the doctor. My kids cannot possibly understand what it's like to go to a doctor. And my kids are all grown, by the way. I survived 5 children. College tuitions are paid. We are in the green. We got some grandbabies now. Life is good. Life is good. But I remember telling my son, about telehealth and how we have to jump through so many hoops to get telehealth paid for. And he said, no, 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 Mom, that's not how it works. Sounds like everybody's son. No, you don't understand. That's not how it works. No, you just go on the app. The app tells you to call in at 2:30. And I was at the beach and she made me go sit in the car, but whatever. And yeah, my allergies, and I picked up my prescription on the way home. And here I am, Mom, look, I'm a responsible adult. That's not how I remember it happening. Right. And that's not how it happens for everybody, by the way. So I think he pays $55 a visit, which he's totally okay with, and he doesn't have to go into an office. So if we were to look at the Medicare benefit manual today, and we were to see how does Medicare pay for telehealth, we would see that the benefit manual still reflects pre-COVID rules. But during COVID, we had something called the waiver. The waiver is something that's built into the Social Security Act that says under extreme circumstances that the federal government has the right to waive certain requirements of payment during that period of time. Does that make sense? So again, they never changed the benefit on how telehealth is paid. So let me share this with you. Telehealth, the payment for telehealth services is contingent on the patient being in an original site location. And that original site has to be a certain type of location. And only certain providers, only certain services, and it has to be synchronous, happening in real time. It cannot be a store and forward. So text messaging is not considered payable. Telephone is not considered payable. Emails are not considered payable under the telehealth benefit, right? So again, right now, it sits in the books that the patient has to be located in an originating site that is outside of a metropolitan statistical area or in a healthcare provider shortage area. So they can't be in their home. And only in certain places in the country can a patient receive telehealth. I know you have a look on your face like, what? No, I don't, Christine, I don't know if you know what you're talking about. No, really, this is what it says in the book right now in the manual, right? As Medicare even went as far as to put together an analyzer that you can type in a patient's address and it'll tell you if that patient is eligible to receive telehealth benefits. Now, of course, they can't be in their home. So they have to be either in a practitioner's office, in a hospital, in a nursing home, in a critical access hospital, rural health center, a federally qualified healthcare center. So they have to be in one of these types of facilities to receive telehealth. So wait a minute. So you're telling me I have to leave my house, go to a doctor's office. I already live out in the middle of nowhere. And then I can go to a doctor's office and get telehealth with another doctor that is somewhere else? Well, that's okay. Now, they only allow certain providers too. It can only be a physician, MD-DO, PA, NP, clinical nurse specialist, registered nurse anesthetist, some clinical psychologists and social workers only for mental health services, a very select set of services there. Some registered dietitians and nutritionists. That's it. Well, what about physical therapy, occupational therapy, speech language pathology? They're not part of the benefit. Under the waiver, they only under the waiver. Let me start. The premise of this conversation is to get you involved, to get you to advocate. We can't have change. We can't have permanent change. We will go back to this as soon as Congress lifts the waivers that have been put in place. So this is what the true benefit is today in the Medicare manuals. Now, the other thing is that we cannot do telehealth across state lines unless that provider is licensed in both states. So if I'm in the state of Florida and you're in the state of Arkansas, my doctor in Florida has to be licensed in the state of Arkansas to do a telehealth visit with Jennifer. If he's not, then he can't do that. There is something called the Interstate Compact, but not all states participate in the Interstate Compact. So Arkansas and Florida do not participate in the compact. In order to be participating in the compact, providers have to apply for a license. Whoa. They have to apply for a license, and then they can only provide services within the states that participate in the compacts. So right now there are 39 states that participate in the compacts, District of Columbia and Guam, and we have about 70,000 providers who are licensed through the compact to provide services in those 39 states across state lines. And the other thing is that the visits, when the patient is at the other doctor's office, we'll pay about $20 for that doctor's office to host the visit that the patient's at. I think the medical assistant probably makes more than that $20, or the table paper, or the lease, or don't get me started, right? So they do have an originating site fee for that place of service. Visits also have to be in real time, face to face, and we have to be using a HIPAA compliant software. How do you know it's HIPAA compliant? You have a BAA, a business associate agreement with them that says that the software is HIPAA compliant. You should also look in your contracts when you sign up for any of these audio video type of technology that they are designated as HIPAA compliant. Only in the states of Alaska and Hawaii can we do asynchronous, a store and forward. And a lot of that has to do with the time difference. So if you realize, like right now it's nighttime in Alaska, so it would not be possible for a patient in Alaska to go to a doctor's office to see a doctor here in Louisiana today, now in real time. They're all in bed. So they do allow a visit to be recorded and have that video sent with the data to another physician. And we have a modifier that we use when it's a recorded visit that is sent off. And then there are only about 109 permanent services on the Medicare covered telehealth list. Most of those do not include new patient visits, only for established patients. And most of those services don't include things like physical therapy or a lot of the things that were added during the public health emergency. All right, I know that was a bummer, but of course, during the public health emergency, we blew the barn doors open. We said, we can't possibly limit people to a geographic area. Everybody right now is in an area of crisis, right? They considered the pandemic to cover the entire country. And so they said, we are invoking the 1135 waiver component of the Social Security Act to allow us to waive some of those requirements that I just shared with you because they're unrealistic during this time of sickness in the country, right? So they put out an interim final rule back in 2020, and they said, we are going to allow certain things. We are going to allow, with consent, telehealth services for office visits, for store and forward visits, virtual check-in visits, digital visits, online visits. We're even going to open up telephone visits that had never been covered in the history of Medicare. So they said, we're going to allow these things. We are going to allow telehealth in all areas of the country. Again, the whole country was affected by a pandemic. So in essence, there was a need nationwide, not outside of the country, right? So if you went on vacation to Panama, England, you could not have telehealth, right? But anyone within the United States, and the patient can be located in their home. Their home could be wherever they're residing at the time. So if Nana comes to stay at my house is her home right now. If my friend Kim, who lives on a cruise ship, is on a cruise ship, as long as it's in U.S. waters, then that's her home, right? So they said we're going to expand that out. They also said, we're going to allow providers to do telehealth from their homes without having to add their home address as a place of service during the public health emergency. So let me see, you're at home, your doctor's at home, and you're having a telehealth visit. And they said, we're going to allow that. They also said that they were going to open the provider panel out to physical therapy, occupational therapy, speech pathology, audiologists. There were some pharmacists that were also allowed to participate during the public health emergency. So they kind of opened that up as well. And this was not actually something in the waiver from the Social Security Act. This was something that the Office of Civil Rights under the Department of Health and Human Services, they said, look, we know that all practices out there can't immediately go buy a HIPAA compliant software. Again, we're in the middle of this emergency that is happening, so we're going to allow providers to use their judgment and use any type of forward-facing camera system like your phone when it's facing you. So you can use FaceTime, you can use Facebook Messenger, Google Hangout, Zoom, and Skype. Because we're under a public health emergency, you still can't use TikTok, you can't use Facebook Live and things like that with a rear-facing camera because nobody wants to see what's going on in their room, let's be honest. They also opened it up to all types of other care that had not been on the list before. They added an additional 153 services to that covered telehealth list, which included new patient visits, emergency room visits. They opened it up to observation care. They opened it up to physical therapy, occupational therapy. They opened it up to all of those services being allowed to be performed via telehealth. And of those 153, 83 of them could be done audio only. And I appreciated this. I travel a lot. And recently I was in West Virginia. Really, a lovely country, lovely countryside. No cellular service, no internet service. I was old school in it, like looking for those old phones that were a phone booth out there because there was nothing for miles. And it's not just there. There are other areas of the country. There's areas in Colorado where there's no bandwidth. Do you know that? That's amazing to me. So we had to be able to communicate with patients. So they opened up psychotherapy, behavioral health. They saw a lot of success in those areas. We learned a lot during the public health emergency. Speech therapy, psychological evaluations, medical nutritional therapies that were being done via audio only. And we were having some evaluation and management visits done via telephone as a last resort, of course. Now, one of the areas that we immediately jumped on and made permanent changes was in the area of Tele-Mental Health. So actually, the Consolidation Appropriations Act of 2022, so going back way over a year ago, because we're really working on 2024 now, almost 2 years ago, they made some great changes there for telehealth services, and for mental health and for substance abuse disorders. So for the diagnosing and the treating of substance abuse disorders and mental health disorders, they were lifting some of those restrictions from the geographic restrictions permanently. So again, if you go to the Medicare manual, all of the old things that still are in place are there with the exception of Tele-Mental Health. So mental health diagnosis or substance use diagnosis that has a new benefit under Medicare only for those conditions where they're allowing that geographic location requirement to be waived, and they're allowing patients to receive face-to-face audio, video, interactive telehealth in their homes. Now, there are a few little restrictions there. It's only for established patients, so there does need to be a face-to-face visit, but there's a delay on that. We're going to talk about some of those delays, but the new rule says it's only for established patients. Again, there's a delay in place for that relationship. Also, patients can be, pardon? So the Consolidated Appropriations Act of 2023, so following year later, extended some of the waiver requirements to have that established patient relationship. Under the public health emergency, they said, we're changing this, but we're holding the established relationship. You can have new patients because we're still under public health. And then last year's Consolidated Appropriations Act extended that out. So again, the rule says it has to be an established patient, but that's kind of on hold because we were granted an extension on that waived requirement.
Like the Runaway Act, when it was held that
Mhm.
it's not a requirement for a while, first 2 years or so. But has that come back?
It hasn't come back yet. Everything is still pandemic. So what was happening there, the Consolidated Appropriations Act of 23, this last one, gave us an extension out to the end of 24.
And do you know also, do they also extend the big treat from the state line?
No, that actually ended with each state's state of emergency. So for example, I'm from Florida. We lost our state of emergency in June of 2022. So as of June of 2022, you had to be licensed in the state of Florida in order to do telehealth to a patient in the state of Florida.
And you couldn't afford what they did in another state.
You could not unless you were licensed in that state. Yeah, yeah. So the actual state line licensure was associated with each state. Yeah, and not federally. Another thing with Tele-Mental Health is that they said there needs to be one face-to-face initiating visit within the first 6 months of receiving telehealth services, and then subsequently once every 12 months, that patient needs to have a face-to-face visit. Now, any provider in the group practice can do that face-to-face visit. So if you happen to be the psychiatrist or the clinical social worker that treats the patient and you're not there, someone else in the practice could see that patient for the face-to-face visit. They also said that they would give an exception to that once every 12-year visit if it was documented that it was counterproductive, right? Maybe it would regress the patient. Maybe the patient's condition was getting better and they only saw you once every 6 months. Well, it wouldn't make sense to have to come in once of those 2 visits every 6 months. So there were some exceptions that they made to that. They also said that audio only could be used under certain circumstances. So the patient does not have access to audio video communication. The patient, not the provider. Provider has to have audio video communication, but the patient may not, right? We're doing this for diagnosis, evaluation, and treating of the patient. Maybe the patient doesn't consent to audio video. Oh, I'm not doing that. I don't want you to see what my house looks like. I'm not, that could happen. And in the event that it is an audio-only tele-mental health visit, we're using the modifier FQ. Modifiers are often used to communicate to a payer that there is some circumstance that has happened around a particular service that has been reported. And so the FQ modifier says that this was provided audio only. The only way to make permanent change is to prove to the payer that this is a need, that we have patients that are utilizing this, and to see whether it's being done correctly. So I'm a huge advocate of using the modifiers as they come out, because that's just how we communicate with the payers that we need this. Now let's talk about the future of telehealth, and for that, you need a calendar. Not gonna lie, with all these ifs, ands, buts, and changes, yes. So again, let's start from the beginning. The official telehealth benefit hasn't changed, but we did have things that were waived during the public health emergency. And with the anticipation of the public health emergency ending, the Consolidated Appropriations Act came in and extended some of those items that were waived beyond the public health emergency. So when it ended, in May, some of those services were extended throughout. One of the things on here that is really important is the Medicare Physician Fee Schedule's proposed rule. So hopefully you're all aware that every year Medicare makes changes. And in order to make those changes and for them to be official, they have to propose those to the public. So it's about 2,100 pages this year, Sandy? Yeah. And it says these are all the things that we want to change in the Medicare program and how we pay for the Medicare program and the fees that we're going to pay for the Medicare program. And they give us a period of time to comment. That period of time to comment is coming to an end, my friends. It's the 11th of this month. So we got about, what, 6 days left to comment? Yeah. There is an incredible fact sheet out there from CMS. So if you put CMS fact sheet, Medicare physician fee schedule proposal, you'll get the highlights. You don't have to read all 2,100 pages. Lucky you. Right? We have to comment. We have to say, we want this to be permanent change. We want you to remove all of these requirements that are just ridiculous. We no longer live in a world where the patients have to come into the office to have a telehealth visit. We have been doing it for the last 3-4 years via audio video technology, and it's been working, right? We have to make those changes permanent there. Some of the changes, again, some of those waived things were extended out to the end of 2024. So we have about a year to see if they're going to make it permanent. But this year's proposal is the year that we're going to see the prediction of those changes. So here are some of the things that they're talking about. The public health emergency ended on May the 11th. There were some things that ended on May 11th. So as of May 11th, they ended the allowance of new patient services. So these services are available to established patients only for the virtual check-in process. Is anybody billing the virtual check-in process? Do you know what the virtual check-in process is? Can I tell you? Do you ever have patients that call the office and say, you remember that rash I came in and saw the doctor for 3 months ago? Well, it's back. Should I keep using the cream that he gave me, or do I have to make an appointment to come in and see him or her? And the doctor looks at the chart and says, if it's the exact same rash, yeah, they can use the cream again. That's reimbursable. I know, right? But it's only for established patients. During the public health emergency, you could do it for new or established patients. I don't recommend starting something in a practice unless you have a compliance program and you educate your providers on the documentation requirements to report these. But they reimburse about $20 a visit. And can you imagine how many phone calls you get per day if you could put a value behind that, right? Those virtual check-ins cannot be related to a visit that has happened within the last 7 days, and they cannot result in a visit where the patient comes in the next 24 hours. So if the doctor wants to see them for that rash, then when it's not a reimbursable phone call, we'll see them for that evaluation and management visit. But if he doesn't or she doesn't want to see that patient, and that's totally okay, or I'm just going to refill that medication for them, then that's reimbursable. The other thing that ended on May 11th was for remote patient monitoring. During the public health emergency, you could bill for an entire month of remote patient monitoring when only 2 days of data had been captured. Well, they changed that. At least 16 days of data must be captured in order to report a month's worth of remote patient monitoring. So that went back to normal immediately. Another thing that ended on May the 11th was telehealth visit frequency. So we were allowed to have a patient that was inpatient for subsequent visits. They could be seen every day via telehealth. Now they can only be seen once every 3 days via telehealth. A patient that is in a skilled nursing facility can only receive telehealth services once every 14 days now. During the public health emergency, they could be seen as necessary within that time period. And then those that are in critical care, those consults can only be reported once per day. So during the public health emergency, we saw that extended beyond that. So it's all returned back to its original state. And I share this with you because if telehealth goes back to its original benefit, it will affect all of us greatly. Now, one of the things that was extended till the end of 2024 were the services, the ability to provide certain services via telehealth. What they did not extend was which one of those 153 codes were they going to extend until the end of 2024 or infinitely. During our proposal right now, that we're looking for a final rule to be given to us in usually November-ish, They're going to tell us which one of those 153 additional services are going to stick and which one of those 153 services will be done. And we can't do them via telehealth anymore. So again, what I come to you with is advocacy. If you're doing any services via telehealth, you should be commenting in the next 6 days to Medicare and say, whoa, please don't take this away from us. We're doing physical therapy via telehealth for therapeutic exercises, and it's worked in our practice. Please don't take that away. Jennifer.
So what you're saying, just for clarification, is
yes.
Monday is the day.
Yes.
It will not potentially be part of the final rule.
It won't impact the final rule. Your thought process won't impact the final rule. And again, I want to remind you that we have a voice. We have a voice to make change in how things are paid and reimbursed and allowed in the Medicare program that influences the Medicaid programs, that influence the TRICARE programs. And we have to be involved in that decision, right? So again, that's what I'm saying is by Monday, if you're doing any telehealth services or thinking of doing telehealth services or want to do telehealth services, please let Congress know what that is. What do you use and how do you want this change to stay or be modified, right? Yes.
As a patient, we're all patients.
Yes. As a patient, as an employee, as an advocate, as a provider of service, from a payer's perspective, a hospital perspective, an office perspective, or just my perspective, I write every single year on any of those items that are listed in the proposal that I think that either need more information, whether I support it, if I don't support it, I say why, my concerns, and what's an alternative to it. I want my voice to be heard. And here's the neat part. You want to be famous for 5 minutes? When the final rule comes out, they will say, Christine Hall commented and said, don't do that. Don't take away our telehealth. We love it. We need it. There's your 5 minutes of fame, guys, right? And forever it'll be documented that you had a part in making some real impactful change. Oh, it's the CMS fact sheet, and it's for the Medicare Physicians Fee Schedule, or the MPFS proposal. Yeah, if you message me, I will send you the email address and the written address to submit your comment. Now, there are some things that are ending in December. So we will no longer be able to report any deep brain stimulation, some of the physical therapy codes, emergency department codes, cardiovascular and pulmonary rehabilitation. Those are ending. And the other thing that is ending is the parity payment for telephone visits. So at this point in time, if you have to see a patient via telephone, they're in rural West Virginia, they don't have access to cellular or internet, they're making a visit via the telephone, that right now the parity is there. So you'll get paid just as much for that telephone visit as you would for an in-person office visit. That parity will be leaving us at the end of the year. That's the parity I was talking about. Oh, and the document you're looking for is right up in the left corner. So it's the CMS 1784P. That's the 2,100 page document. So you're looking for the fact sheet that's referencing the proposal there.
I still don't understand, like, telehealth services provided in the office. If I'm putting hands-on, why is it still being billed as telehealth?
Because the doctor you're seeing is somewhere else. So think of,
Going to your primary doctor.
what state do you live in? Okay, so you're in Virginia. Say that you're in Arlington, and the doctor, the specialist that you need to see is all the way on the other side of the state. You're not going to be able to go get and see that doctor. So you're going to go to your doctor in Arlington. They're going to put a camera in front of you and a screen, and you're going to see that doctor who is on the other side of the state. That's the way that telehealth was being done. That's the way that it is in the benefit. That's the way that it is written as a covered service. Yes. So I'm in Florida. It's a huge state. Huge, right? It takes about 10 hours to get from one end to the other end, right? And that's not Key West. I'm talking about, that's even more. So it's not feasible that I'm going to go to a doctor 10 hours away. But what if that's the only specialist that takes my insurance that specializes in the condition? That's your only option, right? Did you have a question?
I do, but don't you think they're using telehealth in a, I mean, there's definitely a positive of telehealth, but there's such a negative to it as well.
Yes.
So they're taking these physicians and they're stringing them out and they're seeing so many patients and they're really not diving into the situation that the patient's going through. So, you know, I mean, I've got a case right now, literally just today, where a neurologist came in and said, you know, touch your nose.
Yeah.
And I said, oh, you're totally fine. And it completely screwed up the acute transfer that I was in the process of getting this patient to.
Absolutely.
So that's, I mean, so there's.
We need your voice to help us find those boundaries in telehealth. So I have a very similar two separate stories. I have a patient who suffered from allergic dermatitis, horrible, for years, saw the same dermatologist for years. One telehealth visit, the dermatologist looked out the patient's window and said, "Is that a pepper tree in the yard?" "Yeah." "How often do you trim that tree?" "Oh, every 3 to 6 months." "Like every 3 to 6 months you come to see me with that same rash?" "You're probably highly allergic. Let's get you tested and let's see if we can no longer have you messing with that tree." Right? That'll be in your best interest. So that was a positive thing I heard. The other thing was, just like you said, where they're seeing a specialist who is very limited with no physical exam. So is it that we don't do initial visits? Is it only for stable follow-up visits? Is it, right? And that's where we need our voices to be heard, is to say, I don't think that we should dismiss telehealth, but should we put up some boundaries, right?
Health.
Right.
I see my therapist every more often than admit to, but telehealth. So I don't even have to take time off work. I'm sitting there in my office with the door closed and the noise machine on.
Right.
And whereas it would be undoable for me to, you know, get in the car, drive 30 minutes there.
Right. And you unpack everything and then you have to pack it all back up. And that's difficult, right? So it works for some. It doesn't work for all, but we need voices to talk about where those boundaries are. Yes.
It also teaches, I mean, malpractice is probably behavior.
Yes.
And it teaches skill therapy. Right.
It does. Correct.
At actually reading over a visual and having the patient say, no, you can't see my face.
And they don't have body language. Right. No, I agree with you there. And that's why we need voices to give those concerns, to say real live scenarios that are happening, and how do we keep the benefit without losing the integrity of it?
So you said your voice, and then you also said the fact sheet. So are you marrying up those two?
When you read the fact sheet, the address and the email is on the fact sheet where you can read these items. They aggregated some of the top items on there. And you can read that fact sheet and see, how does this impact your office, your organization? Do you want to keep it? Do you not want to keep it? Do you want to? No new patient visits, right? So only established patient visits. Under what circumstances? But again, if not, we run the risk of losing perhaps this great opportunity to see those patients. Like I said, my mom's visits, we had great outcome. Maybe the pediatric visits are great, mental health visits are great, but maybe certain specialists, orthopedic, probably not, right? I mean, I'm sorry, is that a bone hanging out of my leg? Jennifer.
I'm a consultant for podiatry. I actually am a consultant editor for a podiatry newsletter.
Right, podiatry via telehealth? No, I mean, no, right? Right, exactly. Yes.
I had a couple questions.
Sure. Awesome.
And this Medicare stuff is so money for providers to figure out.
It is.
And I'm going to tell you, when I was in the private sector, there would have been no way for me to ask a patient who was in Michigan where I practiced if they were in a different state traveling, unless I said, are you in a different state?
Yeah.
Where you live and I routinely see you. And then I switched to an employee-based practice.
Mm-hmm.
So I know this is reimbursement, but are there some of these things that are nuances for licensure if you're a direct, receiving direct pay or employee-based care?
Well, the licensure does not change. So even if you're an employee-based, you still have to be licensed in both of the states. Oh,
The rules for the telehealth visits, are there rules?
this is for anyone who participates with Medicare. So if you are with a group that participates, if you are independent and participate with Medicare, or you're treating Medicare patients, all of these apply. Yeah.
Even if I'm not practice assistant,
Pardon?
even if you're not billing Medicare.
If you're not billing Medicare, it's going to be dependent upon the individual insurances that you're billing.
Sure. So it's
Okay, so if you're concierge, you don't do any insurance at all. The only thing you really need to worry about then is how are you doing telehealth? What's the modality you're using? Is it HIPAA compliant? You have your business associate agreement in place, so you know that it is, and you read your contract, you know that it is, and then licensure. You need to be licensed in whatever state your patient is and in whatever state that you are in.
And malpractice insurance.
And, thank you. Yes, and make sure that your malpractice insurance is covering you treating patients via telehealth modality. Yeah, that might make a difference as well. Yeah. So just to finish up here, the telehealth actually for federally qualified healthcare services, they have removed Tele-Mental Health as a telehealth benefit because you're only allowed to have certain telehealth services in a federally qualified or a rural healthcare center. So they just said any Tele-Mental Health is not going to be considered from a payment perspective as telehealth, right? It's a different type of modality there. This is the information for you to comment. So if anybody wants to take a screenshot of this, this has the email address on number 1, electronically, number 2, regular mail, which may not get there by Monday, and then by express or overnight mail is number 3 there. So if you want to comment, very important. We are the only ones who can really influence change is by saying those things. One of the things in the proposal that we talked about was to increase reimbursement based on what? And what Medicare said over and over again is nobody sent us proof of their costs. So we can't raise the rates if we don't see that your rates have increased, right? So just quickly to remind you that we are now past the extension that was given to us by the OCR. The Office of Civil Rights never actually said that you could use those modalities, Facebook and things. They said that we'll turn a blind eye. We won't audit you. We won't come after you if you're not using a HIPAA compliant because we know we're in a public health emergency and that you can't just go out and buy one willy-nilly. But they did say that effective August the 9th, so as of last month, you must be using a HIPAA compliant software. Again, that business associate agreement is going to be key into assuring that you are using one of those types of softwares that are HIPAA compliant. The DEA also extended out some regulations for prescribing controlled substances via telehealth for established patients there, or extended a period of time in order to establish a relationship in order to provide controlled substances via telehealth. Now, you do need to check with your states to see if your state has a more strict requirement for telehealth. So that one's going to be by state there. Again, lastly here, the Office of Inspector General is currently conducting 9 audits on telehealth services. So we should be seeing those reports coming back to us, hopefully by the end of this year, beginning of next year, so that we can see some of the problems that we saw with telehealth services being provided. But again, I think it's important that we observe those and we think of how we can do it differently in our practice. I would hate to see telehealth go back to the way that it was, which was inefficient in many ways. But I also don't want to see where it's prohibiting care in certain areas because we just don't have the correct boundaries put in place.
I was just saying in general, like I was affected by the pandemic mentally myself, and I know a lot of people were. Where some of us are still not of that mind frame where we just want to get out of the house sometimes. Like we still, everyone in the country still feel like
I stand 6 feet from anybody. I get in line and I'm looking for the little thing on the floor, like, where do I stand?
we've still
Right?
for a long time. I think we've all been
Yeah.
kind of messed up by it. So I think it's going to be a while.
Well, thank you so much, everyone, for staying for my session. If you have any questions, I'll be here all week. My name is Christine Hall, and my information is very easy. C Hall at Sterling Global Solutions. Sterling is spelled with an I, Stirling, for any of my fellow Scots.